Bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities:
Hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And welcome to today's webinar titled Translating Emergency Knowledge for Kids, Part 2, Bridging the Research to Practice Gap. Before we get on to the presentation, I just want to make sure everyone's familiar with the process here. As always, we take your questions at various times throughout the presentation, so I encourage you to type your questions into the question box, which is in the bottom of the little control panel that's usually on the right-hand side of your screen, and type them in as you think of them. Our presenters have a number of spots throughout the presentation where they're going to be taking questions from the audience. So please do type them in as you think of them, then we'll have them ready when the presenters are ready to answer them. You are free to come and go from the session. It doesn't interrupt the session at all, and we do record the entire webinar, so you can always go back to the recording and catch up on any parts that you might have missed. The recording and any other resources or documents provided to us by the presenters, such as the PDF of the PowerPoint slides or anything else that we may be able to share, will be posted to the CAFC Knowledge Exchange Network. Occasionally, because of unpublished research data or certain images or other things that might be in a slide deck, we aren't able to share them, but if the presenters allow us to share them, we will post them on the Knowledge Exchange Network. It usually takes a few days to get that up, and you will receive an automated message from the system with a direct link to the page, although you can always use the search function on the CAN as well. The CAN does provide for comments for registered users at the bottom of each page, and we encourage you to continue the discussion following this presentation and post any comments, questions, or other information that you think might be of interest to the people participating in this session. So it's my pleasure to again introduce an organization that might be familiar to us. If the presenters are not familiar, the organization is. As many of you may remember, back in February, we had a presentation with our colleagues from TREC, the Translating Emergency Knowledge for Kids program, which is a knowledge mobilization initiative funded by the Government of Canada's Networks of Centres of Excellence. Some people may know that as the NCE program. And they did join us back in February for an introductory presentation to TREC, and they sort of presented some of their preliminary work around some surveying. And this is part 2, where they're going to, I believe, they're going to tell us what they've done since then, based on their initial surveys and some of the other initial work that they've done. So we're very excited to welcome a couple of new presenters today with Dr. Mona Jabour, who is a pediatric emergentologist, the Vice Chair and Chief of the Department of Pediatrics at the Children's Hospital of Eastern Ontario, CHEO, and she's also an Associate Professor in the Department of Pediatrics at the University of Ottawa. And we're also happy to welcome Dr. David Johnson, who is a pediatric emergency physician, medical toxicologist, and a professor of pediatrics and physiology and pharmacology, and a theme lead at the Alberta Children's Hospital Research Institute at the University of Calgary in their Faculty of Medicine. So it is my pleasure to hand the virtual podium over to Dr. Johnson and Dr. Jabour.
So first, for those of you who aren't familiar with TREC, we'll be giving a brief overview of our vision, mission, and strategy, and also a few results from just some key results from our needs assessment. It's important to understanding what we'll be talking about later, which is our implementation strategy. Following that, and a quick series of questions, I'll just review best evidence regarding how to change professional behavior. What many people may not know is there's actually quite a lot of evidence about how best to get professionals like ourselves, physicians, nurses, allied health professional, etc., to change behavior. And so I'll be giving a quick overview of that. And followed by that will be the meat of our presentation, which will be given by Mona Jabbour, when we'll talk about the implementation strategy that we're taking for TREC. Yes, so the next thing we'd like to do is just to ask you what, just to give us a better idea what your interest in TREC is. And first of all, are you an ED healthcare professional, 2, an ED hospital administrator or educator, an interested health consumer, or an international participant?
So this is just your chance as the audience to go up and provide your input. So just go up and make your selection on the screen there. And by international participant, they're talking about any clinician, researcher, or administrator from outside of Canada, obviously. We'll just give everyone a few seconds to put in there, make their selections. And just another few seconds for everyone to click on the screen and make your choice, and then we'll turn this around. All right. So it looks like it's a pretty close between ED healthcare professionals and administrators. 38% saying ED healthcare professionals, and 43% saying emergency department, hospital administrators or educators, and then 19% saying interested health consumers, and no international participants today.
Okay, that's terrific. So the second question we'd like to pose of you is how familiar you are with TREC. A, I'm just learning about this now. B, I have some awareness of TREC. C, I work at a TREC site. D, I'm formally involved with TREC, a site champion or participant.
All right, so we'll give everyone just another few seconds. I think we've got people leaning forwards in their chairs now. Their answers are coming in a lot quicker this time. All right, we'll close that off. And it looks like most people are just learning about this now. Some have some awareness of TREC. Some 15% work at the TREC site, and another 15% are formally involved with TREC. So,
Great, that's terrific. And then one last question for you. How many of you attended the previous TREC's webinar presented by Terry Clausen and Shannon Scott? Select either yes or no.
And again, that was the one that we presented. I believe it was back in February. And of course is posted on the Knowledge Exchange Network for those of you who didn't. So 70% have said no, they didn't attend, and 30% said yes.
Okay, terrific. So that's very useful. Thanks very much. So we just wanted to make sure we're taking the right approach here in terms of giving some people some background information about TREC. Our apologies for those of you who might have a very good understanding of TREC already. So first of all, as Doug mentioned, TREC is one of 3 networks funded by the Networks of Centers of Excellence, a knowledge mobilization initiative, and those are quite unique. If you move to the next slide. The vision of our organization is to deliver the highest standard of care to every child, whether they choose to seek treatment in a pediatric or general ED. The reason why that's so critically important for us is because, as many people may not be aware, something on the order of about 85% of all kids who are taken for emergent or urgent care go actually to general emergency departments. And so even though the vast majority of kids are seen in general emergency departments, of course there are many, many more of them, and as a result the volumes at general emergency departments are comparatively lower. And as a result of that, any given healthcare worker in a general emergency department setting, nurses, physicians, allied health professionals, see comparatively few. And so because of that, we know there's quite a substantial gap in knowledge that people have, and it's not because of not wanting to do a good job, it's just because there's a vast ocean of information out there, and they need it distilled down. So TREC is committed to working with our colleagues from general emergency departments to try to provide the best information possible so that the care delivered to kids around the country, whether they seek care in very small, remote, rural general emergencies or a children's hospital emergency department, is the best possible. Next slide. So this slide gives the sites for all of the emergency departments, both general emergency departments and pediatric emergency departments across Canada. There are a number of sites that are part of Pediatric Emergency Research Canada. That is a research network that spreads across the country, and of which Mona and I are active participants in. And that the PERC sites serve as sort of a core around which each of the TREC sites, the 35 general emergency departments, relate to. And so as you can see here, quite a wide number of sites. The 35 emergency departments are broadly divided into three sizes. First size is a very large general urban EDs that see, actually in many cases, quite substantial number of kids. A second group are those that are in regional cities, the Red Deers of Canada. And so there are equal numbers of those. And the last are smaller rural sites, not the smallest sites, but ones that still have a fairly substantial volume, but are in distinctly rural, remote areas. So, for example, well, I won't mention any examples of that. So let's move on to the next slide. Mona, can you move on to the, yeah, thank you. And so then the broad vision, the broad mission of organization is to create a national network that's a trusted source for easy access to the latest information. And we are actively working with all of the members of the TREC sites, the 35 general emergency departments, as well as pediatric emergency department staff, to develop this trusted source of information with a hope that we can, as we've said before, deliver the highest quality of healthcare for children. Next slide. And so we're basically we're doing this knowledge mobilization strategy in three large steps with a fourth plan for the future. And so the first is we've done a very extensive needs assessment of the 35 general emergency departments, both the staff and the families that attend them. Following that, we've gone through an extensive mapping of evidence relevant to the top priorities that these staff and families selected to make sure we had best evidence and the best kinds of consolidation of information that we could provide to those sites. And then last, and this is what we'll be talking about today, what Mona will be presenting about, is to provide these general emergency departments with really efficient, we hope, ways of accessing that information and having it available as they need it, as they work along. Our plans for the future are to hopefully enlarge the size of TREC, so increase the number of communities and general emergency departments that are part of it, and also hopefully do some innovative things. For example, to be able to have active knowledge translation research projects where we can really get a sense for what works and what doesn't work. And you'll get a little better sense for why that's such a compelling need when we move to the next section. Mona, please, next slide. And so just to give you a quick overview of our needs assessment, if you could just go to the next slide. The team that carried this out really spent a lot of time doing it and are very highly qualified group. Shannon Scott, who is at the Faculty of Nursing and an expert in quantitative research and knowledge translation, especially focused on children. Lisa Given, a colleague from Australia, and the project coordinator, Lauren Albrecht. Next slide. We did a detailed survey, which we collected from 32 out of the 35 sites. Some of the sites came on recently, and so weren't able to participate in the initial needs assessment. And so the way we gathered this information was through iPads. And so basically coordinators from the Pediatric Emergency Research Canada, the PERC site coordinators, went out to each of these hospitals and spent time there and tried to track down as many of the professionals, healthcare professionals who work on those sites, and also went out into the waiting rooms to talk with families who are bringing their children to be seen to get care and ask them questions. And so we did it in both French and English, and we did it over about a 16-month period. Next slide. So we got a total of just under 1,500 total survey results, which came close to about 60% of all the healthcare professionals who work at each of those sites. Then as well, we surveyed just under 900 families of children who were presenting to the emergency department. Next slide. In addition to taking information from that survey, we realized that there might be some unperceived needs out there. In other words, information that might be important for operating clinicians in each of these sites that they just it doesn't come to mind when you ask them that question. So we looked in 3 different ways to try to get a better sense for that. First of all, we have an extensive database within Alberta where any physician who needs to make a referral has to operate through this referral system, and they get connected with the transferring site, the site to which you transfer the patient. And so we used that data as well. We got data from the CMPA, which reviews claims from patients, families who are concerned about the care they've received, and so identified cases there. And then as well, within Ontario, there's a pediatric death review committee, and so we reviewed deaths of any children under 5 to see what the issues were and added any problems from that to our list. Next slide. The third thing we did is that Shannon Scott led a series of focus group at 7 TREC sites, allowing her to explore in depth in a qualitative way what sort of interest they might have, realizing that when you ask survey questions, you get sort of standardized answers, but sometimes you get better insight from a more systematic exploration, and you can follow up themes. Next slide. Whoa, there's a slide missing. Mona, is the slide of the 12 or so.
This is the next slide. Okay, that's coming next.
Yes. Okay. There we go. My apologies. That was my error. My fatigue this morning. I did an emergency department shift late last night, so a little underslept side. So my apologies. Okay. So once we got all of that information, then we did a series of things. So first of all, Dr. Lisa Hartling, who's a epidemiologist at the University of Alberta, and also really a world's expert in systematic review, led a very extensive review of all the literature available around how to manage acutely ill and injured children, and really focused on those things that were prioritized by our committee. Our group got all of that information together. That group was led by an emergency physician, and Doug, Mona, you're going to have to help me here. I'm blanking on Doug's last name.
Doug Sinclair.
Doug Sinclair, my apologies. Result of my fatigue, thank you. And so they essentially took all the information that we had available, that we showed from the needs assessment, and as a result of that, we sifted through, I was a member of that committee and worked with them, and we sifted through it and made decisions about what were the top priorities. And so these are the list of things that we came up with that we'll be showing you shortly. And so those are a total of 14 conditions. As you can see, as you move to the right, first, how they were identified. So the 10 that are checked are those that came from the survey. The ones that are checked under unperceived need came from the various sources that we talked about. And then the last came from focus groups. The numbers on the right indicate the priority in which we're going to do them. It's not always reflective of the importance, but rather we wanted to take a few low-hanging fruit that we had a lot of information on that we could put together and test drive and make sure that the kinds of information that we're providing really meets the needs of the local workers at each of the different participating TREC sites. And so as you can see there, a wide list of things. And I won't read through each of them, but you can scan through them. What we'd like to ask now is, having looked through each of those things, is whether or not these topics fit with your pediatric emergency care needs, for those of you who either are administrators or actually work in sites. And so does it include most or all of your needs, many of the topics, some of the topics, or none or very few?
Everyone a few extra seconds to think about this one and to read through the choices there.
I'll just go back so you can see the choices.
Okay, it looks like most of the responses are, we'll give people another few seconds here. A few more responses are coming in. All right, that looks good. We'll close that off and we'll turn that around. It looks like most of, 67% have said that the TREC topics include most or all of their needs, followed by 13% for each of the next two selections, which were many of the topics are included and some of the topics are included, and only 7% said none or very few of the topics are included.
Okay, so that's terrific information. I'm glad that these topics really address most of your needs. But for those who indicated that there were other topics that really should be included there. We'd really love to hear what those are. And so if you can send emails to Doug, and he can compile that to us, and we can gather that information and include it into our list and have the prioritization committee really consider those topics and incorporate them in. So thanks very much. Next slide. So let's just pause for a few questions now. So that's essentially the introduction to TREC and the needs overview of the needs assessment. So are there any questions?
See if I can see the questions here. It says, we had a question come in here from Doug, not me, asking, was mental health emergencies a topic that was discussed?
Yes, they were. Mona, do you want to talk about that in a little more depth?
The mental health emergencies were one of the many options that were available on the survey. What we've selected here, what we've shown you here, are the ones that really rose to the top in terms of the majority of participants identifying them as an area of need. Mental health emergencies are something that I'm actually personally involved in. A number of us are involved with working on initiatives related to this field with general emergency departments as well, but it's not an area of focus for this round of TREC.
So I have to say I was actually quite surprised that it didn't rise to the top. For example, in our province here in Alberta, children's mental health issues have been prioritized, and it's one of the major focus of our provincial health groups. Having said that, it wasn't amongst the top things that people expressed concern and interest about. So we were a bit surprised by that. Mm-hmm. Next question.
Well, it's certainly, I'll just add, it's certainly anecdotally something that we hear across the country at CAFC as an issue. And in fact, we're having a session at our upcoming conference in October, at which Dr. Jabbour will be joining us to present on some of the work from Ontario on mental health needs in the emergency department. So I think we're a little surprised that it didn't rise higher on your survey as well, because we certainly hear a lot about it. But that's all the questions that we have right now. If you wanted to continue on with the next presentation, next portion of the presentation, we'll wait for some more questions to come in.
Okay, that sounds good. So what I'd like to talk about now is just a very quick review of best evidence regarding how to change professional behavior. And so if you can go to the next slide. So one of the most important things that many people don't realize is that there actually is a great deal of information that we have available to us from various rigorous studies about how best to affect change. Now, there are no silver bullets, which I'll highlight soon. There's no easy way to change professional behavior. But we really know quite a bit about it. And what strikes me in working with people about this is how often people think that their idea about how to change behavior and how it might occur and how effective might be is often based on their own personal sense, their own small anecdote. And I think Mona and I are really committed to the idea that this is not an easy thing to do. And the only way you can really systematically do it and do it effectively is if you really take a lot of care in how you go about doing it. And that starts with being really aware of what the evidence is. So with that, let me just highlight a few things. Next slide. And so the first thing we know is from very rigorous evaluation. So these are what are referred to as cluster control trials, the gold standard for determining whether or not an intervention in trying to change professional behavior actually works well, or what are referred to as time series analysis, another fairly rigorous way of determining whether or not your intervention really makes a difference. We know that the effects of intervention are on average quite modest, and as you'll see in a little bit, they generally average around an absolute change of about 10 to 15%. So meaning that if a certain practice, an ideal practice, is provided to 40% of your patients, then after the intervention you will have improved it from anywhere by 10 to 15% up to 50 to 55%. So that's really our small increments, and that's with extensive interventions. So it's actually very hard to affect change. The other thing is, even though we do have a lot of information, I think one of the things that you'll see shortly is that there's a huge variation in terms of what the studies have presented in terms of the size of the effect of change. And so that we think that the reason for that is that it's a complicated process, and there's a lot of things that might affect whether or not you can effectively change professional behavior or not. And so what those things are, because it is such a complex situation, it's really hard to know exactly what those are. And so at least at the moment we have a limited understanding of that. And the science of knowledge translation is about trying to systematically sort those things out, so you're better able to predict what kind of intervention and what kind of situations actually will yield a maximum change. The third point that I'd really like to make is that these kinds of concerns aren't small. The reason for that, I think, is everyone that's involved in healthcare is aware that we really want to affect change. We really want to do the best possible thing by the children we care for. And so we engage in initiatives very commonly, and we put our heart and soul into those. And so they aren't without significant opportunities costs. You're really focusing on one question versus another. And so if you go about it in a way in which you're not really conversant with the best ways to do that, the pros and cons, and really think through the situation, then you're really squandering an opportunity to improve care to our children. So we just like to emphasize that thing, that one needs to be careful in selecting which topics you really focus on and how you go about doing that. Next slide. And so if you'd like to get a really nice overview of what we know, this reference is the best available. So what it is an overview of systematic reviews and randomized controlled trials and interrupted time series. So all of the more than 1,000 studies that have been published in the world literature. Jeremy Grimshaw is at the University of Ottawa, world's leading expert in knowledge translation. He's done this review for 3 times, and his last review was in 2004. It was such an exhaustive experience that he said this is the last time he's doing it. Even though it's a little bit dated, it's still quite current, and it really provides a lot of information. Now, I won't say it's the most scintillating read in the world. It's actually quite a nice cure for insomnia for those of you who have difficulty sleeping. But it's loaded with information. And I'll just give you a few highlights from his review that give you a sense for what we know about what works and what doesn't work. So next slide. What do we know if you develop educational materials and you systematically provide it to a group of healthcare professionals and then not to the other. How much difference does that make? And so using the cluster randomized control trial methodology, which is the gold standard, there were 4 cluster control trials. And the average, the median change was around 8%, 8% absolute change, with anywhere between a change of 3 to 17%. That compares with audit and feedback, where people actually look at healthcare providers' care that they provide, they summarize it and feed it back to the clinicians, and usually comparing them to their peers. And that can be done in a number of different ways over a number of different time courses. And there we have, again, quite a number of really rigorous studies, 5 cluster control trials. Again, those are really the gold standard way, the most rigorous way of assessing that. And that varied anywhere from a low of a 1% change, effectively no change, to a high of 16 absolute percent change, with a median effect size of 7%. The last example that I'll provide you with is around reminder systems. And so what are reminder systems? So it can take a number of different forms. And so, for example, if one put posters up in the emergency department or in the inpatient unit saying what the best practice is, a new clinical pathway, that could constitute a kind of reminder system. Another thing that's considered a reminder system are computerized physician order entry, where you have programmed in key alerts to remind patients, physicians who are making orders what the optimal treatment is for a given kind of patient. So all of those are examples of reminder systems. And there we have a total of 14 cluster control trials. And we've had ranges all the way from a -1%, so effectively no change, to as much as 34%. So a very substantial change with a median effect size of about 14%. So as you can see, quite a lot of variance between one and another, but none of them overwhelmingly successful. So there, as I highlighted before, there are no silver bullets. Trying to change professional behavior is hard work. It's a true contact sport. Next slide. And so many of us think, and I know that some of the earlier reviews that Jeremy Grimshaw did suggested that if you threw the kitchen sink at healthcare professionals, you tried a lot of different things, that actually worked better than if you just did selectively one thing versus multiple things. In his latest review, the one I showed you for 2004, the results are discouraging, at least in the case of saying that more is better than less. As this slide shows, it suggests that one well-targeted information can be just as effective as 4 or more. So just to explain the slide, on the x-axis, it's the number of interventions that were done. The smaller number is the number of studies that were looked at, and those aren't all cluster control trials, but there are a bunch of other kinds of interventions, pre-post studies, time series interventions, those kinds of things. And on the left, on the y-axis, is the effect size. And so as you can see there, and this is called an IQR, a Whiskers plot, which shows you the median. So the center in the red is 50th percentile, and the 25th percentile is the lower bar, and the 75th percentile is the upper bar. And so as you can see there, there's really no difference one all the way up to more than 4 in terms of the general effect size that we see. Next slide. So I'll close with my general comments about what we know, is just to highlight that when you're thinking about KT interventions, it's really important to think about at what level you're trying to work. Is it at the level of the individual healthcare professional? Are you targeting healthcare groups or teams? Are you targeting higher level organizations? Or are you trying to affect really sort of large healthcare system or environmental changes? And each of those really take different approaches, and you wouldn't anticipate that those would all lead to the same benefit. I know our experience is, Modus and ours, is we've done quite a lot of rigorous studies where we've looked at what kind of change you can affect from a range of different kinds of intervention. Mona and I think both feel very strongly that when one is trying to affect change, it's really important to focus not just a selected group of healthcare professionals, so for example physicians, but rather instead that you really focus on the entire healthcare team and you really get everybody involved and make it as much a team effort. Now, having said that, I'm not aware of any studies that have looked at that in really a systematic way that are published. We did a study here in Alberta a number of years ago that we haven't gotten quite yet published. We hope that it'll be coming out soon, which showed that working with healthcare, the entire healthcare team seemed to have no more benefit than working with physicians, targeting physicians, or any intervention. So it was a negative study. It was one of those studies that showed no overall change. And so even though at the time that we were doing it, we had a real sense of optimism that we were really doing a great job. We had nurses and physicians, particularly the nursing staff, really excited about what we were doing. When we finally looked at the results, we saw a positive overall trend over a series of 9 years that showed that the care of children of croup was getting substantially better each year. We were having increasing use of corticosteroids, the best way of treating children with croup. We had decreasing hospitalization rates and decreasing decreasing costs throughout the 24 hospitals that we systematically looked at. But the intervention that we didn't seem to be the cause for that. Rather, instead, it was a secular trend. So just highlighting how important it is to systematically evaluate what you're doing and realize that, boy, it is a hard thing to affect change. Okay, so with that, I'll move to the next slide and open it up to questions. Oh, one last thing I forgot, my apologies. If you're interested in exploring more about what knowledge there is, you can go to this site, which is part of the Cochrane group. This is based at Ottawa, and there's a wealth of information there, including formal definitions of the different kinds of implementation strategies that have been used over the years, and you can get a sense for what the various things that people have looked at and what kind of evidence there is. So now we'll move on to questions.
Much, Dr. Johnson. There haven't been any other questions come in yet, but this is again just a chance to remind the audience, type those questions in as you're listening to the presentation, as you think of them, just type them in so that we have them available. And so we can hand the podium back over to Dr. Jabbour, I guess.
Okay, thank you. So I'll move on.
Dr. Jabbour, I just wanted to mention, you sometimes fade out a little bit and get a little bit quiet, so if we can just make sure we're nice and loud so the audience has lots of room to adjust their volume as they need. So.
Okay, great. Thank you. Thanks for that reminder, and let me know if I'm fading again. Thank you, David, for that review. And at this point, I'd like to describe our implementation plan for TREC. And before I start, I'd like to first remind you it's hard to actually speak when you actually don't see who you're speaking with. And we're both really looking forward to your feedback about some of the topics we're discussing here. I'd also like to acknowledge the work of our TREC team office, and in particular our knowledge broker Lisa Nisley and Carly Leggett, who's recently joined the team, for all of their work, and in fact the work of the entire network of our TREC and pediatric emergency site representatives and coordinators. It's really a tremendous team, and the details of what I'm going to be describing wouldn't be possible without the work of the whole network. So thank you to everybody. Of the four main goals that David presented earlier, the third goal is really, in essence, what I think we're all about at TREC, and that's assisting emergency teams in the access, adaptation as needed, and implementation of new knowledge related to their care of pediatric patients and their caregivers. We know from studies done in asthma and croup, as well as others, that a child presenting with a given condition is likely to be managed differently depending on which emergency department they present to. And that's largely because we're not practicing based on evidence. Thanks to the growing field of pediatric emergency research, new knowledge is really helping us to better manage our pediatric patients. And the more that we are practicing based on this evidence, the more we're able to narrow that gap in variations of care. But as David mentioned, we know that there's a lot of challenge inherent in that. There's challenge in staying up to date. And that's why essentially we've developed TREC. We've created TREC to really help in that process of making sure that you're having the most up-to-date knowledge really accessible to you at the bedside. So based on what we've heard from the TREC sites in terms of what is needed and how to make this available, we've focused our deliverables on three key areas. First are the quality tools that will be accessible through our central resource repository on our website, trec.ca, and I'll show you that later on. Information resources for patients and caregivers, and on-site professional development sessions, which we've found from our survey have been shown to be very important to healthcare professionals across the TREC sites. So I'm going to begin with a discussion of the quality tools. For each of the priorized conditions that David showed you earlier, we plan to provide three types of tools. One are evidence summaries. The second are point of care, or what we call bedside resources. And the third are tools that will support learning related to that specific condition. It'll take some time before all of these materials are fully available, but we have already made a very good start. And we're working with the TREC sites to ensure we provide the most appropriate formats and accessibility options for these materials. So to begin with evidence summaries, anyone working in an emergency department recognizes the wide breadth of knowledge that we're required to maintain. And as I mentioned earlier, the challenge in keeping current and remembering all the recommendations in various fields of emergency medicine, especially if they're really only needed sporadically, is really challenging. So for this reason, we're providing expert summaries of the evidence for each condition in one of these three different formats. So knowledge pyramids, infographics, and clear language summaries. Healthcare professionals are looking for different types of information at different times depending on their situation. Are they in front of the patient? Are they doing some background reading? Are they learning about something for the first time perhaps? So depending on where they're at, their needs are different. We see knowledge pyramids as an optimal way to put the best evidence together to allow health professionals to decide for themselves what to read and review. This is a schematic here of a knowledge pyramid, and while it may not look like this per se on our website, all of the relevant components of the pyramid will be there. So at the base level are the key primary or landmark studies in the field. The next level up includes the systematic reviews that combine the evidence in a rigorous manner from those very best studies to provide more powerful findings. Going the next level up are clinical practice guidelines that rigorously review all of this evidence and provide recommendations for diagnosis or management. In settings like the emergency department, even clinical practice guidelines might be too difficult to implement. And so these are operationalized into clinical pathways or decision rules that can be readily used at the bedside. And finally, at the peak of the pyramid are the bottom line recommendations that will guide our decision making in the emergency department. To make these bottom line recommendations even more accessible, they will be provided in two formats. The first of these is the infographic. This is an infographic sample for gastroenteritis. This was developed by Lisa Hartling's group, and we received a lot of very positive feedback from our TREC representatives on this type of a tool. The infographic is well organized to allow you to focus visually on the key points of treatment, summarizing the evidence behind each of the treatment options or issues. And it may be difficult to see that, but if you look, it talks about oral rehydration therapy, anti-vomiting drugs, probiotics, or placebo. And it talks about different scenarios and what the evidence really tells us. This is the second page of that infographic, and it gives you a summary. If you don't want to look at the visual, it gives you a summary of the findings for each of those different treatment scenarios, and then a summary again at the end. And it is a very visual document that is accessible really to everybody, including patients and families. For those providers who really just want the bottom line details, we've also included clear language summaries that are one-pagers that highlight severity-based treatment recommendations and diagnostic criteria. These evidence summaries will be helpful to share new knowledge and ideally promote learning related to management of these conditions. But the summaries may themselves still not be sufficient to help you at the bedside for a given patient. And so for this reason, we will also provide what we call the point of care tools that can be readily used at the bedside to ensure the standardized best evidence approaches are available to all patients where relevant. This is a list of bedside tools that will be accessible through our website, trec.ca. I'm assuming that many of you will be familiar with each of these, clinical pathways, medical directives, pre-printed order sets, drug summaries, written discharge instructions, and patient information summaries. So in the interest of time, I won't describe any of these in detail, but please feel free to ask if you have questions about any of these. Many of these resources are available through our TREC network thanks to the collaboration of our pediatric emergency department sites. There is significant collected expertise across these sites, and the bedside tools that they have developed and updated over time are an excellent resource for emergency department teams in all settings. So we've really just combined all of these resources, are providing the best of them, and they will all be available on the TREC website. As a reminder, these are the conditions for which there will be bedside resources on our TREC repository. Not all the conditions will have the same type of resources or the quantity of resources, but over time this will grow depending on interest and availability or development of new tools. And finally, we will have various tools to support uptake of new knowledge. These will include e-learning modules, podcasts from presentations that we've called TREC Talks, to borrow from TED Talks, and user blogs. And again, we see these tools as evolving depending on the interest and the uptake by the TREC community. So to summarize what I've just talked about, our website, trec.ca, will provide 24/7 access to the following vetted and approved resources. So instead of having to go out and look for them yourselves when you've got the patient in front of you, they will all be there ready for you on trec.ca. We're currently working on populating the website with these resources, and as mentioned, over time, this will be more fully developed. So speaking of trec.ca, I thought it would be useful to give you a little demonstration of what is currently available. So as I mentioned earlier, we are doing a series of rapid surveys with our TREC team representatives to get a better sense of what they find useful in terms of the look and feel of the website, accessibility issues, etc., the formatting of the materials that are within the website. And so we're actually just in the process of completing a transition of our website. So what I'm showing you here is an earlier version, but I'm going to just slip out of this presentation mode and go into, which is always dangerous, going into a live mode, but bear with me. So this is a sample of TREC.ca, the resources page, and this is what I was speaking about, where the repository will be housed. What we have here are currently a sampling of resources for bronchiolitis, croup, and gastroenteritis. And there are a number of documents available that relate to that knowledge pyramid that I spoke about earlier. So if you look here, if we choose bronchiolitis, for example, of course it always takes longer to load when you're live. And you can see here that there are 17 documents. There's an infographic, that's the at a glance. There's one clinical practice guideline. There are summaries of systematic reviews. There are 6 of those, and there are 6 individual systematic reviews and 3 key studies. And if you click on any of these, you will see it will produce a list here of the various ones. And you can click on these and it will actually show you the systematic review. It's the original publication of the systematic review, and so on. So you can go to any of these and find the same thing. I'm going to show you here the infographic for bronchiolitis. I had shown you earlier the one for gastroenteritis. And I'm just going to make this a bit smaller so you can see it on one page. And you can see here that, again, it talks about the different treatment options, whether it's glucocorticoids, bronchodilators, epinephrine, etc., different treatment scenarios, so glucocorticoids compared to placebo or bronchodilators compared to placebo. And it gives you a summary of each of the issues related to that treatment scenario. So again, very useful summary findings of all the important research that's been done in the area of bronchiolitis management. And then if you want to get out of that page, you go back to Browse All Resources, and again, you've got that opening page that I showed you at the beginning. At the bottom here, we have a number of the most viewed resources that are available for quick access. If you want to just go to that bottom line summary, it will be there for you. So I'm going to go back into the presentation. And so what I've just described to you is our plan, albeit a very quick plan, quick presentation of our plan for the quality tools that are geared primarily toward health professionals. We're also providing resources for patients and caregivers as well, because they're they really are the central part of our TREC network. And so there are a number of things that we're working on. As I mentioned earlier, on those TREC resource, in the TREC resource repository, we will have patient information summaries, whether it's general information about bronchiolitis or a written discharge instructions that are pre-written and pre-vetted that you can hand to parents for further care relating to their child's condition. We've also engaged a parent advisory group to give us feedback on the types of information and tools that we're developing, and to identify more optimal avenues of reaching parents. In future, we would like to have more tools available to help parents with decision making on, whether they need to come to the emergency department or not, and provide more information that would be understandable to and helpful to parents related to emergency conditions relating to their children. Our other current objectives include creating an e-book for parents and families on croup that would be housed on TREC.ca. We're interested to do further collaboration with community and parent organizations. As I mentioned, our trek.ca website repository will also include relevant information and links for patients and families, and we're working closely with our parent advisory group to get more input on that to make sure that what we're providing really fits with their needs. And then also we're looking at creating new resources such as an asthma ebook for children. And finally, we know from our needs assessment that health professionals at our TREC sites really want to learn through face-to-face interactions. And so because of that, we're planning a series of pediatric emergency medicine professional development sessions to be held at the TREC sites. And this really is, I think, a fairly big endeavor, but one that clearly has been called for. So we're focusing on two main types of outreach sessions. The first are face-to-face education sessions that will highlight evidence on a given topic and will also reinforce use of the bedside tools that we've described earlier to help reinforce their use. So instead of just talking generally about asthma and the latest findings, we're going to focus around real cases to illustrate diagnostic and management decision making and show how the resources can really help with that as well. And where possible, we'll also be providing simulation-based training sessions. These will focus on approach and decision-making around the more stressful, high-acuity, but low-frequency types of scenarios where a simple presentation really just isn't enough. You have to experience it, and really that is a more optimal way to learn how to manage in a resuscitation situation. As mentioned, we will also record these sessions for use as TREC Talks and/or make these sessions available as webinars to really help maximize the learning potential for all these sites. Now, I will say that based on our experience in providing outreach within our Champlain Lynn in Eastern Ontario, and probably David's experience in Calgary as well, that it's very difficult to organize these outreach sessions. It's difficult on our end to actually get the faculty together to go out and do these outreach sessions, but there is an interest and a willingness to make this happen. On the side of the community hospitals, it's really difficult when you have a small staff to begin with to spare people to attend an education session when emergency departments are 24/7 operations. So, we'd really be looking for help with the TRECs from the TREC sites to help organize these sessions so that they can get maximal value for everybody. And then finally, e-learning modules will be available, as we mentioned earlier, to support ongoing learning. So for example, David's group has developed an e-learning module for gastroenteritis for a clinical pathway to support the use of the pathway. In Ontario, we've developed an e-learning module for asthma. I believe David's group has done that as well. And we will be looking to develop more e-learning modules, again, depending on interest in this type of a learning support tool. So I've alluded to this a little bit in this last slide, but in terms of implementation support and to build on what David presented earlier, implementation really is a challenge. It's difficult to take all of these tools and actually do something with them to integrate them into the operations of emergency departments that really have so much going on already that it's hard sometimes to take on something new. What we'd be looking for from the local emergency departments in terms of responsibilities are supporting the access and use of the TREC tool, so ensuring that there are computers available that health professionals can actually access these tools, and to work on focused implementation of the specific tools. And we're certainly available to help with strategies for implementation. And you would, of course, need to adapt the tools as relevant to meet your local infrastructure and contextual issues. From the TREC perspective, we will definitely be providing support in all this implementation endeavor, not just with the resource repository or the outreach sessions that we're conducting, but also help with sharing of best practices on how to do this implementation and providing other support as needed as it comes up with your implementation. So with that, I'd like to leave you with a final polling question, and we'd like to hear from you. So after hearing about this TREC presentation, please let us know where you're at. So either A, eager to make use of these tools, B, motivated to get your team using TREC, C, interested but not really sure how to begin, D, just too overwhelmed by other priorities, or E, click all that apply. And it's possible that all may apply.
And we did change this question up a little bit, so there is no click all that apply. It's select as many of those as apply. So you can make you can choose more than one of the selections when you're checking the boxes. We'll give everyone a few more seconds to put in their responses. All right, so we can close that off, and we'll turn around the answers. And it looks like, fortunately, not too many. Only 8% said they were too overwhelmed by other priorities, and 58% said they were motivated to get their team using TREC. So that's a good sign. 33% said eager to make use of these tools, and 25% said they're interested but not sure how to begin.
Well, that's fabulous. Thank you. I'm very motivated by those responses. That's great. And I'm also motivated because if I remember your responses from the first polling question, either the first or second, that most of you are either health professionals or ED administrators or educators, and you are certainly the ones that are going to be doing the heavy lifting on implementation. You probably recognize what the needs are in your department and know that the work involved in doing it, and despite that, you are still motivated to be using our TREC tools. So we're very encouraged by that, and like I mentioned earlier, are definitely willing and available to help you in that process. So that's the end of our formal presentation. We wanted to leave time for questions, comments, other feedback that you might have. So while you're thinking about that, I'm just going to go through a few more slides. First, on how to connect with TREC, we have a number of different options depending on what your interests are, how you like to connect and communicate. These will be available on this slide deck as well. So please feel free to contact us in the best way that works for you. And also, you can click on this YouTube link to share the TREC story. I think this may have been shown in the first webinar, but since many of you weren't on that webinar, that information is available to you as well. And I think the last thing I'd like to say is thank you. Again, ask for your questions and leave you with the contact information for TREC, our email address and phone number. So Doug, I'll turn it back to you if there are any questions.
All right, there have been a few questions come in, and I do encourage people to check out that video. It's also right embedded in the front of the TREC website. It's a great little sort of video that explains what TREC is all about. We had it up on our blog a while ago, and there's lots of interest in it there, so it's very well done. So I encourage people to go and check that out. The first question, we had a few questions come in from Tara. She's asked, and in fact, this first question you may have answered, but I think it's worth going over again a little bit. She's asking, how will you make smaller hospital emergency departments aware of TREC so they can access these resources?
Okay, that's a good, is it Tara? Did I get her name right? Doug?
Yeah, it's Tara,
oh.
yeah.
Okay, all right. So how will we make smaller emergency departments aware of TREC? And that is part of our broader question. Certainly, you know, resources are finite in terms of what we have available to do what we're seeking to do with TREC. And so the strategy really began with a more doable number, a smaller number. So we have 3 emergency departments, community emergency departments affiliated with each of the pediatric sites for a total of 36 emergency departments. Ideally, our goal is really to have as many emergency departments as possible aware of TREC and using TREC. So part of that is going to be through word of mouth and sharing of resources, presentations at conferences or other places where health professionals attend. Also notifying families through the health consumer side of TREC about the resources available as well. For now, we really are focusing on the TREC sites in terms of the active implementation. We will try not to turn anybody else away, and certainly the TREC website will be accessible and available to anybody who wants to go there. But our focus for now really has to be the TREC sites in terms of the active support of implementation. David, I don't know if you wanted to add anything to that.
No, I think you did a really good job of outlining our approach.
Okay.
The next question, also from Tara, she was just asking how long, when you were talking about the repository of the systematic reviews and the guidelines and the other information there, how long before that site is populated? You have a little bit up there, but do you have a timeline as for when that gets expanded?
That's a good question. Being an eMERGE doc, my timeline is usually on the order of hours, maybe days. Web developers work on a bit different timeline. They have done quite a lot of work actually in reformatting and doing all that back-end work to websites that I don't really know anything about. I can't say, and if Lisa is on the call, she might be able to give us a better indication of when that would be available. It's certainly active work that we are doing now to make those resources readily available. And although I presented a broad list of things, it will be in a staged manner that we will actually be releasing this information, because we want to make sure that it's as good as possible before we're putting it out there.
And I am on the line, Mona. I don't know if you can hear me.
Yes.
Yep. But in terms of timelines, yeah, we are hoping, what we're aiming for is for all of those conditions is to have at least all of them up on our website. And as you mentioned in the presentation, some will be much more populated than others depending on what evidence is available, but that they will all be addressed by the end of March of 2015 on the website.
Thanks, Lisa. And we also had one more question from Tara. She was asking if she says, have you considered making TREC tools as part of the nursing curricula? But I think that could apply to any. Have you thought about connecting with educational institutions for any program, nursing, medicine, or any other healthcare providers, and getting them connected to these tools?
That's an interesting question there. We have thought about that and discussed that. For now, as I mentioned, our primary focus is the TREC sites, the 36 community emergency departments, but we actually have been approached by a few different organizations specifically with that in mind, integrating it into the nursing curriculum. I want to make sure I have the school right. It's BCIT in British Columbia. Lisa, what's that school? The nursing school?
Well, the BCI. Oh, hello?
Yeah, go ahead.
Yes, the British Columbia Institute of Technology is one of the schools who is developing a new curriculum. And that may be Tara, actually, who's answering. Maybe, I may be wrong, but there is a educator there by the name of Tara at BCIT as well. So, but that is one of the schools that is developing a new curriculum for pediatric emergency, and a specialty program for pediatric emergency for nurses. And
Tara has commented that yes, it is in fact her that is asking the question.
Hi, Tara. It's fantastic you're joining us.
Yes.
All right. Well, that's we'll give. We don't have any more questions in right now. We'll give everyone a few more seconds if there's any other questions. We've used up most of our 90 minutes that we have scheduled, so it is just about time to close. But maybe we'll give people another few seconds to type in any last burning questions, and maybe we can hand it over to our panelists for any closing comments. Lisa included. Feel free for any sort of final comments that you might want to add.
Doug, it's Elaine. Just a quick comment and offer/question perhaps. David and Mona, thank you for that fantastic, absolutely fantastic presentation. This is amazing and incredibly important work. CAFC, at the time of sort of in the initial development stages of TREC, we remain very committed to being a KT partner. And I just wonder at some point if we could think about connecting in a very sort of comprehensive way the TREC site, the repository in particular, to the Knowledge Exchange Network, and just sort of making that, because our target, your target, community hospitals, children's hospitals, are largely representative of CAFC's member organizations. So I see a tremendous opportunity for KT and through the wonderful technology that we're both using, maybe taking advantage of that. So just that as a comment. Does that make sense?
Thanks for that, Elaine. I think we're all enthusiastic about that opportunity and look forward to working with you.
Okay, so just put that out there as a possible future possibility.
All right. Well, we don't have any other questions coming in. So again, any final words before we sign off?
I wanted to say thank you to CAFC for hosting this webinar and really helping us to bring TREC to an audience that maybe hadn't heard about us before. And it really is how we're hoping to spread the word about TREC. And we really are interested in your suggestions and comments about what we're doing. We're always looking to improve. So thank you for your attention and your interest. And thank you, CAFC.
All right. And Dr. Johnson?
So just to echo what Mona said, we really appreciate the opportunity to tell you about TREC, and we hope that you've enjoyed it and you found it informative.
All right. Well, thank you very much to both of you for a great presentation. And again, I do encourage everyone to go check out the trec.ca website and the video and all of the other resources they have there. It's all very well done. So I think you'll definitely find some value in all of the information that is currently on the site. And of course, as we now see much more to come. So thank you also to our audience for joining us. As we close off this webinar, we do our CAFC Presents webinars every Wednesday at 11 a.m. Eastern Time. So we hope to see you on any of the upcoming webinars. You can find out information about any of future webinars on our website at cafc.org by just going to the CAFC Presents section of the website. And our next webinar will be, we have one coming up from the Patient Safety Collaborative, which actually is not Wednesdays, is Fridays. And then the next webinar is from the CAFC Presents webinar series on the Wednesday is on virtual reality for pediatric neurorehabilitation. So we hope to see any of you that are interested in that topic on our next webinar. And as I mentioned, any resources will be posted on the CAFC Knowledge Exchange Network, including the recording. So you should get an email from us in the next couple days. So until the next webinar, thanks for coming, and we'll see you then. Bye.